for a bit.
Sorry.
It's okay. There you go. That's a little bit better.
Okay. I don't understand the lighting in here. It's like some kind of
It's coming through the window.
brown
Yeah, it's the backlight from your window.
That's okay.
Well, I also have lights on. Hold on. Well, that doesn't. Okay, I'm not going to worry about it. And the ring light is in the basement because my son's shooting another music video. So he does all these music videos with his friends.
Well,
they're really good.
Yeah. Well, it looks like we have, yet another wonderful public health debacle on our hands. I mean, this is just. I was telling Kelly sort of when we were talking just now that when this came up, I saw it. And I hate to say it, but my immediate reaction was like, of course, like I'm so used to these types of errors, these egregious and seemingly purposeful types of errors now. And I hate feeling that way. It is really like not a good place to be.
I can't even get mad about it anymore. I mean, I just can't, my mantra.
I'm mad about it. But
COVID has not increased the respiratory disease death burden among children. I mean, like, that's just what I say, right? Like, sorry, move on.
Well, that doesn't seem to work. The evidence and the data doesn't seem to change anything. Well, here we are. Welcome to a long-awaited another live with the Team Reality peeps. I'm Eric Hartman here, broadcasting from the deep blue reaches of Westchester County, New York. I'm a captive.
Yay. And I'm Jessica Hockett. I'm in suburban Chicago, and I have oodles of light flooding my face. and
very artistic. Yeah.
It's like my own Instagram filter. It's great.
It is. You need like sort of an angelic drone behind you. And we are obviously joined today with Kelly Kay of Georgia, who has been, just kind of doggedly, investigating these data errors, over the last, 2 years. And, you've caught quite a few of these so far. Too many.
Too many.
Oh my goodness. What's going on this time?
People, so this one, people sent it to me. I didn't even come across it on my own, but it's gotten to the point now and people see numbers that they find suspicious, especially with kids. They send it to me and they say, what's up with this? That can't be right. And so someone had sent me the slide that was shared by Caitlin Jedalina, your local epidemiologist. And then someone else had sent me the preprint and they're like, have you seen this? Do you know what's going on with this? And I didn't know at first even that the two are connected until I was like, I don't know, where did these numbers come from? What's going on? And I was like, oh, that's the same preprint someone just sent me. And I was like, well, looks like they're using the wrong numbers. I was like, the footnote clearly says they're using numbers from NCHS, which is where these numbers come from and what populates wonder. But I immediately was like, they made the same mistake that Jeremy Faust made 2 weeks ago that I just corrected, which was using the multiple cause of death numbers from those NCHS download files.
Is this the one?
Mm-hmm. So yeah, somebody, and I don't even know if somebody had sent me that, but they had replied to it. And then, they instantly somebody that wasn't even like a person that's kind of down in the, numbers was like, this includes stuff that's, not COVID. Right. And I was like let's see if it does, let's see what it does include. And so I was like, oh yeah, it includes the multiple cause of death. So if you have COVID anywhere on your death certificate, they included it in these numbers. But then they compared it to a ranking that that's only underlying causes of death, that doesn't have those multiple causes listed. So that's kind of an apples to oranges, but also their preprint 4 separate times says they included underlying cause of death for COVID, which is wrong. They didn't. I don't know if they thought they did, or I don't know if they just said they did, but that's That's just not true.
Well, but so really quick, I mean, to your point, anybody that's been following this looks at this and knows that this is not true, right?
Yeah. I mean, if you've been following it with an eye of knowing that kids have, been the least at risk, if you've been following this and your prior is, this is like a life-ending event for children. I mean, there's people that are very, very scared for kids. And so they see these numbers like, see, that's everything I've known was happening.
And it comes from this person who is apparently an epidemiologist, an educator, professor, world traveler, lover of ice cream and the ocean. She's a mom of 2 under 2, assuming that's twins, founder and author of Your Local Epidemiologist. This is an appeal to authority. This is blue check, grifter, the science striking again.
Is Caitlin British? Is she from the US?
No, she's not. She's here in the US.
Okay. She's a traveler with 2 L's. That's why I asked.
She got it, I'm assuming, because she was watching the ACIP meeting that morning, which I think is why she took like a cell phone picture of her screen.
Yeah. She doesn't know how to do the key command.
Right. So, but if you see the left edge is cut off, which is where it has the CDC logo. So that's why I didn't even clue in. I was looking at it on my phone. I was like, where did this random slide come from? This isn't right. And I started looking into it and I was like, oh, I see the preprint that it comes from here. And I saw the issues there. Then I'm like, once I pulled up the preprint, I was like, oh my gosh, they use the cumulative numbers. And sure enough, when you look at the footnote on the slide, it says they use the COVID cumulative numbers. So they compared the number of, the ranking of deaths from 2019 for one specific year. They pulled out of Wonder. And then they went and downloaded a text file of deaths that had COVID anywhere on the death certificate, and then just wedged them in. And they wedged them in both as the cumulative number and an annualized number. So in every age group, they actually had COVID listed twice, like ranked twice, which just makes no sense. Like if you wanted to use both numbers, at least you needed to have 2 separate rankings,
It makes complete sense if you want to scare the crap out of everybody.
Well, I mean, the cumulative being on there does, but actually putting the cumulative on there pushed down the annualized one for everyone. Like for 1 to 4 year olds, or let's see, actually the under 1 is the easiest to see, because for under 1, the COVID cumulative was listed as 4, but the COVID annualized was listed as 9th. Well, if they hadn't included the cumulative, COVID annualized would have been listed as 8th. Like, so it actually, I mean, it gave this cover for using a really high ranking, but then actually artificially kind of lowered the annualized number. But then because the annualized number was still based on the wrong data, that still wasn't even right. Like, so it was just kind of all, I was like, this is junk. Like, I mean, this is just like high school, like science fair, bad grade kind of junk. Like,
it's embarrassing.
I was just stunned.
I noticed when I saw the slide, I always read the title first, right, before I read the table. And it says COVID-19 is the leading cause of death among children ages 0 to 19 years. Children in these data for the CDC pediatric is 0 to 17, right? So that was my first thing. Like, can we please get children correct? Because once you start adding in 18 and 19-year-olds, there's all kinds of things that start to factor in with causes of death.
And they've been doing that little trick since late spring of 2020.
This is the thing where that actually was introduced by the CDC, not even the study authors, because the authors say leading cause of death in children and young people.
Okay, sure.
So it's the CDC that kind of exacerbated that. And that's the same thing with the cumulative. The CDC is the one that chose to use that cumulative ranking. They know they chose it because they listed it here in their footnote. They were focused on that under 5. So I think it didn't really bother them that it went to 19 and they just wanted to say children, because, they're trying to talk about children. But, I mean, it's real. I mean, it was very inflammatory to be able to say top 5 for every age group. And it's going to be probably top 10 for every age group once the new version of the preprint comes out. But that's a very different story. It's I mean, those causes of death, as we've talked about, are very skewed towards the top 1 to 3, depending on the age group and what they are. And that top 1 is accidents for most age groups.
Sure.
And that includes so many things that individually still would be higher than COVID. If you broke out accidents instead of number 1, if you broke it out into vehicle accidents, let's see, vehicle accidents.
That's another one, right? That accidental smoke inhalation is a cause of death. It's very different
for young people. Yeah, it's for the very youngest. It's fire and smoke inhalation is one of them. Vehicle accidents, drownings. For older kids, it's vehicle accidents, it's overdoses, and those are just. And then you still have this category of all other accidents. So, I mean, that turns accidents into at least the top 3 if you break it out into these different buckets. And someone had actually tweeted this morning that I thought was funny. They said, I was going to pull it up here so that I quote them correctly. They said, it's amazing how many people don't appreciate how we choose to bin data has a huge effect on the conclusions. For example, did you know that asteroid strikes are the second leading cause of human deaths, behind only non-asteroid strike deaths?
Right.
I'm like, that's exactly true. If we just say, depending on how we group these makes a huge difference in where they fall. And at the CDC, the head of the NCH has been quoted saying, these are arbitrary buckets. Like, we've just decided as a CDC, this is how we want to categorize it. But it doesn't make COVID any worse or less for kids based on the ranking, on an arbitrary ranking.
Sure. And then you get into the sort of the from v with issue as well.
We still have that issue.
Which again, they don't want to talk about. Here's our friend Caitlin again, right? So you had somebody respond to her, showed a coworker, and he said, did they die of COVID or with COVID? Which if you want to solve this thing, right? If you want to be an honest broker, you want to ask this question because there is an absolute difference. And, if you've been at all paying attention over the last 2+ years, what kind of artificial incentives are in place with our medical system in terms of, coding COVID, right? Especially, and we see how they use these things. If somebody comes in on in a motorcycle accident, they test positive for COVID, there is a monetary incentive as well as a statistical incentive to have that person die from COVID. Is that the bulk? No. But the problem is we don't know how many that is. We don't know what that split is because of these artificial incentives. It's a real
children,
problem.
That percentage is much higher than for adults. Like, there's often quoted of like, only 10% of these multiple cause deaths, don't have COVID listed as the underlying. So they say, look, 90% of the deaths that have it, it's the underlying cause. But for children, for young children in particular, that becomes more like 60%.
Well, this is her slide trying to prove
end up being underlying cause. And even those underlying causes, we know there's some where, it's just easy because we test for COVID all the time. Even if you don't put any consideration into the monetary aspects of it or whatever, but just to say, look, we tested for this thing, we know it's bad, and a kid that had it died, it's easy to say, well, that's probably what did it, and to not look further.
Sure.
Even in cases where we now know they have looked further and actually found it was something else. Right. But it's just everybody's right now is focused on COVID. So when you see a sick person and they have COVID, I think it's just human nature as a doctor. You think, well, that must be what's wrong. And there's times when that's caused problems where people, things weren't identified and things weren't taken because it must just be COVID. It's going to be, we need to treat this as COVID.
Right. And this slide that she tries to use to sort of prove her point is admissions. And I don't know about where you guys are, but when Omicron, sort of came sweeping through the Northeast over, Christmas and New Year, everybody was freaking out when their kid got the sniffles, and turns out a lot of them did get Omicron, which we know was very, very mild. they would take them to the emergency room. They would take them to the hospital. And just because somebody is admitted and the primary reason they're admitted is COVID, again, this doesn't have a connection to those deaths in the previous slide at all. Like, this is literally just like they were admitted.
Yeah. And admitted for, it says they would considered a COVID admission if they had a fever or a cough.
Right.
Like so that doesn't even mean it was COVID.
Right.
And when everybody has COVID, again, it might have been that they, it's the data just isn't as clean as everybody would like. And that's the thing. So many people, want to get on this like COVID versus the flu or COVID versus this. And I just keep like, the numbers aren't clean enough for us to make these definitive statements that people make on either side, really. I just think that the data is just way too muddled. Like, we haven't seen reviews of these deaths, so we don't know how accurate these are. We know that we count COVID differently than we've counted flu, so it's very hard to compare with that. We know that, when you test for something, it's easy to document it as that, whereas, a similar death under a similar circumstance that also would have been preceded by a flu infection or something would not necessarily be counted the same way.
Right. Add in the extremely oversensitive tests, right? And we can certainly grant that there's false negatives as well. But, when you crank these PCR tests up so much and you're catching, virus, remnants and all sorts of weird stuff, and the monetary incentives, right, to the hospital networks for COVID related things, which, were, passed with the best of intentions, right? Because, oh my God, we're closing everything down. The hospitals are going to go out of business. We need to provide them with monetary remuneration for, COVID stuff. Again, it's like good intentions once again, causing massive problems.
So I was looking like with the MISC deaths, like that's people where they didn't necessarily even know they had COVID, but they have this inflammatory response. We do antibody testing. We say, oh, it looks like they had COVID in the past. So, this is MISC. And then it's coded as COVID causing, if they die, or even if it's just a hospitalization, as COVID being the cause.
Yep.
Now, in the case of flu, flu can lead to Kawasaki disease, which is very similar to MISC, as well as other respiratory viruses can lead to that. But in that case, we would never go through and we wouldn't test for influenza antibodies or whatever. Like, we would say, oh, this is just caused by a virus, and we wouldn't go test, and we wouldn't, assign it to the virus. We would assign it to Kawasaki. And so it's specifically, we cannot, they said, based on how flu deaths are defined, it can't be a flu death, because a flu death requires that you never recovered from your flu infection, which is definitely not the case for COVID. So there's a lot of definition things that just are very different. That just, even when you try and you use the numbers that theoretically are apples to apples, they're still not apples to apples. But then it's really exacerbated, like in this case, when you go through two different steps to use numbers that don't compare by using apples to oranges on top of that. Of we have the different testing and ascertainment issues, but then on top of that, we're going to add, we're going to compare underlying to multiple causes, and we're going to compare 26 months to 1 year, which, neither of those decisions make any sense and just further erode trust, because there's just no integrity in using numbers that are that, different and not comparable.
Totally.
Eric, you said earlier there's no connection between the hospitalizations on that slide and the pediatric COVID death numbers. But what's interesting, I just now looked this up actually, and this is true for adults as well, adult age groups, but most, looks like, almost like 90%-ish, 85%-ish of COVID attributed deaths among children are in the hospital, right? Which I find that really interesting. Why don't we have more COVID deaths at home, right? Do you have to be in the hospital to die from COVID. And again, that's true in the United States for adults when you look at healthcare settings and where people die of COVID. So in a long-term care facility, a hospital, or a hospice facility overwhelmingly comprises the lion's share of COVID deaths in the United States versus at home, or other non-healthcare places. And
Yeah.
well,
again,
we're so deadly. Would almost all the deaths be happening in the hospital? I'm not sure. I have questions about that.
It so much of it again comes down to the financial, and it's troubling that sort of the COVID maximizers, sort of the apocalyptics, really refuse to sort of look at this, because they sort of brush any discussion of financial incentive off as sort of either conspiracy or it's worth it, right? Like it's based in this idea that COVID is so magical and so horrible and so novel that it required changing all of these rules that we had in place before 2020. To Kelly's point, and with the flu, we didn't do this with flu before. And if you're an honest broker and you want to actually fix this and you want to actually help people, you need to take a sober look at these financial incentives, because they are corrupting. Does that mean that the people that are doing it are bad people? No. Does that mean that there's, evil afoot or a global cabal? No, of course not. But when you pass trillions of dollars, in various bills that give people burial expenses gratis for if their loved one died of COVID, again, it makes the heart feel good. Right? It makes the people that watch CNN in the airport go, oh, we're helping those poor people all dying from COVID. But if you're not adults enough to understand that there is going to be abuse of that, then you can't take part in this conversation. In the same way as, again, to your point, Jessica, like, I don't know what the answer is. I don't know why so many people are dying in the hospital. I think a lot of people would assume they're so darn sick, they go in the hospital and they flop over with COVID. That might be the case. But at the same time, you also have to consider the financial incentives that these hospitals do absolutely have for something to be called COVID, to get reimbursed. And again, they're not in a great place. They almost went out of business in early 2020. They've fired half their nursing staff. They've got tons of problems. A lot of their own making, a lot of the government's making, but they are in this weird money spiral around COVID that is really tainting everything. And I think that a lot of what we're talking about today is because of that.
Yeah, I mean, think about it. You're a county coroner or a doctor, kid, maybe you swab the body after the fact, or maybe, again, the kid's in the hospital, so he or she gets tested for COVID. I mean, losing a child is tragic. It's awful, right? And so if
unthinkable.
I'm supposed to put COVID down if the kid, has tested positive. I mean,
right.
And it means the family gets $9,000. I mean,
absolutely.
Longest doesn't want to give a grieving family. I'm not saying
seriously. If I was working as an administrator in a place where I could make that decision, and it's like you kind of have this thing in your back of the head. It's like, it's free money. Right? Like, everybody else is doing it. Why not help this family? It's like, I can totally understand how this happens. And again, I don't think that these people are bad people. I don't think it's nefarious. I think it's very human. And these incentives are all over the place. It's at every single touch point. We've talked about big COVID from, the testing and these apps and everything. It is so insidious because there's so much money tied to this. And I'm a free market guy. I'm a capitalist, but this is not capitalism. This is capture. This is, government, massive trillions of dollars through government regulation that are creating these sticky, awful, insidious, COVID industries that are really creating massive problems for us on a continuing basis.
Yeah, I agree. Kelly, you saw, I'm sure. Well, the researchers with this preprint, by the way, are from the UK. So part of me wants to give them the benefit of the doubt in working with the Wonder database. Maybe they just messed up. I don't know. But the lead author, Seth Flaxman, tweeted a couple days after you uncovered all of this. And by the way, your work got some well-deserved attention from the likes of Vinay Prasad and
Yep.
who else? Alistair Monroe, Francois Ballou. Is that how you pronounce his name? I don't even know. I'm saying these people's names out loud for the first time. Jay Bhattacharya. And so, yeah, your work, not that it needed to be validated by them, but it is nice when, experts in a field validate your work. So that they gave you props. And then Seth Flaxman has said that he and his co-authors are updating their analysis.
Mhm.
So they're going to get back to us. But I found it interesting that in his thread, in his statement, he said, so far as we update our analysis, our major conclusions are unchanged. COVID is a top 10 cause of death. So he's definitive about that in children of all ages, and the number one cause of death from infectious/respiratory diseases. Kelly, will you react to that? What do you think about? They are going to visit their findings, but what's your take?
Well, I'll point out first, Seth, back in 2020, authored a paper with Neil Ferguson about how super effective lockdowns were in Europe.
That guy.
Deepti is also one of the authors, an outspoken COVID zero advocate. Yeah. So their conclusions are, of course, going to be that COVID is very bad for kids and that they need to be vaccinated. The fact that they brought up that the kids need to be vaccinated as part of their conclusion originally too is
it's an agenda.
Suggested they do this paper. It came out very conveniently 2 weeks before the FDA and the CDC met to talk about these vaccines for kids under 5. And it seems sort of prepackaged for that exact purpose, and was cited by 3 separate CDC employees during the week, during the FDA and ACIP meetings.
Yep.
So, yeah, I would be very curious what discussion went on at the CDC. Who found this preprint? Who decided to use it? Did they all separately decide to use it? Did somebody go, oh, this is going to be great. This will definitely convince people.
We should foil this.
So I find that very interesting. I'll just start there. But yeah, I'm not the least bit surprised that their conclusion isn't going to change, but their numbers are. And the numbers right now, as the original tweet that kind of started this whole thing, it's top 4 or 5 for every age group. Well, that's just not going to be a true statement.
Right.
It's not now. It won't be when the new preprint comes out. Some people seem to see his tweet and think it was going to be worse, that they're actually going back and that they underestimated somehow in their original data.
Right? Because there's always an undercount with COVID. Right?
So I think that'll be interesting. He, in emailing back and forth with me, he had no idea Wonder had data past 2020. I had to direct them to that source. I think now their preprint is probably just going to be basically a set of 4 Wonder queries or 5 Wonder queries. So I'm not really sure why you need 11 people on that. But and I'm curious, we'll see what the dates they end up using, if they stick with their original dates or not. I suspect that might change, which will be interesting to me.
Well, they should just do it by year, ignore 2022 for now. And
if you update if you do a study and then you need to update it because your numbers were wrong, it seems to me like you would stick with the same dates in order, from an integrity standpoint, as far as if you do a study, you can't just change the dates of your study. So we'll see.
Change the date. I don't know, but they could break it down differently, right? And just say, here's the years that we're comparing, or I don't know. I think they could change, but
we'll see. I suspect it's going to be to maximize. They'll pick dates that maximize the ranking as best as possible to support their conclusion. But yeah, partly it is. The preprint had major issues. The CDC's use of it had exacerbated those issues. That's the part that's sort of mind-boggling to me. I'm not at all surprised a group of UK researchers with an agenda put out this paper.
Right.
I'm a little surprised that it outright says they use underlying cause of death when they didn't, because that's just flat out wrong. And I'm kind of surprised they would include cumulative and annualized in the same list. But CDC is the one that made the choice to use the cumulative numbers knowingly. They're the ones that chose to focus on the rank and not point out that, like if you look even at this one here for 15 to 19, even when you use their inflated numbers, annualized COVID is 324 compared to 3,500 for accidents. So even using their inflated numbers, the number one is 10 times what the COVID ranking was. And that will be, that changes even more if you take out those ones where it's not the underlying cause of death. So, I mean, the CDC really here, to me, is the one that, there's lots of bad preprints. Like that part isn't terribly surprising to me. The timing of this one is a little suspicious, but the fact that the CDC jumped on it and used it in the most misleading and dishonest way they could is kind of, to me, the scandal here. Like, bad preprint is pretty run-of-the-mill for COVID news. That really wouldn't have gotten, that got my attention only in that some, predominant Twitter doc or whatever with a big Substack shared it out. But what really, floored me about this was when I realized this was used in such a misleading way by the CDC in these vaccine meetings. Well, now the votes happen. Like, all this data cleanup is going to happen after the votes.
Right.
They don't care. Supposed to be like, do you go back now and re-vote? If you voted based on data that was completely falsified, like, does that now quite?
If they had any integrity, the people that voted on it should demand a revote, right, but they won't.
If it was a lawsuit or a trial, and one of the pieces of evidence was found to be, fraudulent, that'd be a case to retry.
It'd be a mistrial, absolutely.
So, I'm not a lawyer, but you don't just get to fabricate evidence, and then
oopsie,
later when when that all comes out that wasn't true.
That's their entire COVID response, by the way, is oopsie.
Jerome Adams has been, the former Surgeon General, has been tweeting and retweeting this statistic like crazy. He loves being able to say, oh, you have to vaccinate. See, top 5 death. He's said it over and over. Every time he gets tons of replies from, I'll reply, but tons of other people will reply with my blog post and other information for him. And he just ignores it. He's ignored every single response as far as I can tell about it. He continues to retweet it. And then he even posted a tweet saying, I like to engage with people, but when people tell me CDC data is garbage, what am I supposed to do? Well, that's the problem. When the CDC puts something out, there's been news articles that cited this data, and they all said, well, according to the CDC, this is a top 5 cause of death. And I'm like, well, according to the CDC, based on a sham preprint from the UK, like
totally.
But once the CDC puts it in the slide, it's automatically been blessed, even if they did zero due diligence to vet it, and then on top of that, used it in the most inappropriate way possible, and left out, any kind of scale to the rankings or whatever else. It's extremely inflammatory and it's extremely damaging because their logo at the top of that, gives it all
absolutely
everybody needs. So
appeal to authority.
This is not the first time, like Rochelle Walensky. I had to check myself here about the dates and everything, but in October, late October 2021, Rochelle Walensky was saying, oh, there's 745 COVID deaths in children under 18. Well, at the time, there were actually fewer than 500. Now, I know that doesn't sound like a big difference, but when we're talking about these really small numbers anyway, that was a pretty big difference. And she has access to this data. So why couldn't she get the number correct? Or why don't they have an interest in getting this number exactly right and placing the number in the context not only of all causes of death, but specifically, and you guys have heard me say this over and over again, but specifically in the context of respiratory disease deaths. We have at least 1,000 or so, sometimes more, sometimes fewer, but pediatric respiratory disease deaths every year in the United States. We have for a while, past 15 years or so, right? H1N1 was higher. Other years are a little lower. But for me, it's not about, COVID versus flu or COVID versus RSV or whatever. Has COVID increased the likelihood that kids will die of some kind of respiratory disease? And the kids who are legit dying with COVID as a cause of death, are those the same kids who are statistically likely to die with or from or exacerbated by any respiratory disease, right? Like, why doesn't the CDC have an interest in contextualizing that mortality data? It drives me nuts, and I'm long past out of explanations that are generous.
I have some theories.
I think it's very, I feel like it's pretty obvious that they've decided that people are not afraid enough of COVID. They haven't been afraid enough. There was quotes from Fauci early on where he said, people aren't afraid enough. We need to make sure they're afraid of this. That they are just loath to provide any kind of context because they don't want people to, dismiss this. They want people to take it seriously. I think it's very damaging. I think it's super damaging to people's psyche. There's parents that have not let their kids go to the park. There's parents that have not let their kids do any extracurriculars, haven't let them go to school. They haven't let them see friends, even in the yard or whatever. There's kids that have just basically had no human interaction for 2.5 years now. I just think we've done incredible amounts of damage by trying to amplify fear. And now it's it's very hard to kind of put that, back in, put that genie back in the bottle. People are afraid. And I don't think necessarily this vaccine is going to do it. I already saw a quote of a parent who got their kid the first dose under 5 here in the Atlanta area in Decatur. And they said, we're going to keep masking and distancing and being careful. And they're like, but this is such a relief. I was like, it doesn't sound like much of a relief if your kid is still going to have to distance and mask and everything else in the context of the vaccine. And I obviously it doesn't take effect on day one, but he didn't say for the next month, we're going to keep doing that or whatever. He didn't say until they get all the rest of the shots or, it was we just put this fear into people that I just feel like we are having a very hard time unraveling. And the people who are most afraid think the CDC has been downplaying this and they haven't been taking it seriously and they haven't been making a big enough deal about it. And all we see is them telling us these, inflammatory statistics about how it's the leading cause of death and it's hospitalizing so many kids and it's putting kids in the ICU. Without, any kind of context as to what those normal numbers are and, what that means as, compared to other diseases and the fact that we are classifying things differently. To me, it just makes me very suspicious to know that there was some kind of, whether it was an intentional lie or just an ideological bias, that someone saw these numbers and thought, this is a great way to communicate this data. Surely these are right. Or, the most generous is that they saw them and just thought they were right. And went with them. The other option is they knew they were wrong, went with them anyways. I don't know a good way. I don't know any way that reflects well on the CDC to use these numbers. Because as, several people have pointed out, and Vinay in his video, he was kind of like, he was like, he didn't want to offend me, but he was like, these are not brilliant points like I'm making. And I'm like, no, they're not. This was basic reading comprehension. It said they were underlying cause of death. You click on the link, you go to the data source, you read what the data source says, and it says it's not underlying only. And then you look at it and you say, oh, you're comparing 1 year to 26 months. That's middle school, science. Anybody, I'm not doing a regression analysis to prove these numbers are wrong. They're a list. I just pulled up the list and looked at the numbers. I'm good with numbers and I have, some math experience, but I'm not this wasn't like computer science level, statistical analysis. These are just numbers from 1 to 10. These are not.
You know what I think some of the issue is with some of these people, some of these doctors that put out these preprints, and actually I would even include Jeremy Faustin in this. They don't have, they're doctors or epidemiologists, whatever, but they don't really have a context for mortality stats, right? And, I'm the first one to say, I
don't think they care.
Social science, but, I'm the first one to say, I had no idea, like, how many people die in the U.S. every week. I didn't know top causes of death. I didn't know. I didn't know. But in March 2020, when all of this started to go down, I took an interest in, and I don't expect everybody to do this, but in Cook County, looking at every single death is public that goes through the medical examiner. So I started looking through, I started sorting data in different ways. And over the past couple of years, and I'm not an expert, but I've connected with Mary Pat Campbell, who we've had on this show before, and she's an life actuary. She's fantastic, and I've kind of done my own sort of self-study, like with mortality, right, and what people die from. So I have kind of amateur specialty in this, and I find it fascinating. But I think so many of these doctors, people assume that they understand mortality data, right? And I think they don't, right? And then they are like, okay, let's put this together because we want to prove a point. And then they go into wonder and they put all these things together, but they really have no idea what they're doing. Just because you have an MD or PhD or what doesn't.
I specifically called out, I think, is it Benji, who works with Jeremy Faust, who puts together a lot of his data visualizations and stuff, because he shared this top 5 ranking slide. And I commented to him, I said, I'm surprised you didn't notice the errors in this, because it's the exact same error you made 2 weeks ago that I called out and that you had to correct. Like the exact same error of using and comparing underlying cause of death with multiple cause of death. Like, to me, if I had made that mistake somewhere and then 2 weeks later I saw a preprint that made COVID look super bad, I might go, well, I wonder if they made the same mistake I did. That would be my first thought of like, well, I wonder if they did the same thing, or where they got their data.
These preprints, they're not papers that have gone through peer review, right? That's a more extensive process. Mm-hmm. But to publish a preprint, somebody still has to read it, right? I hope more than one person, right? Do we know
this one has 11 authors?
So
again, but this is where it gets.
Them are pretty high profile, as I've mentioned.
Yeah.
But this is where it gets to, again, is it nefarious? Probably not. I still will grant that there's some good intentions or whatever behind this, but there's enough people who are not stupid, right, who are attached to this, where it leads me to believe, and I would bet a lot of money on it, that it was done on purpose. And again, it can be done on purpose for a lot of reasons. And I think, Kelly, you made this point, but it's so much of what's happened to us in the last 2 years in this realm of public health has been via the noble lie, right? Has been from this idea that, we have this novel strategy, this theory, right, of lockdown, and its accoutrements. And it will only work if we get enough people to go along with it. And the only way we can get people to go along with it is to scare the ever-loving shit out of them. Mm-hmm. And that, to me, has been the drumbeat for 2 years. And if you take that and apply it to everything, including, this preprint and the fact that it was chosen, and I guarantee you there was some coordination there. We're gonna foil the CDC on this. But in order to get it into this in time for a vote is in line with what they've been doing for the last 2 years. It's err on the side of scary whenever possible. And, even if, when they can sort of, take the data and focus on a part of it, it's the most scary, they'll do it. And then in this case, they can actually take it and they it's not truthful, right? And what they do is they do the same thing that, a lot of the media does, which is they'll run a very, very bad headline. It gets all of the press. And then when somebody comes and they have to retract it, they'll do a little teeny retraction and nobody sees that, right? That's sort of, been a truth, since as long as I've been alive, but that's the mechanism they use. And then, when you call them out, they shrug their shoulders and they say, well, we're helping. We're trying to help, and you guys are the ones that are keeping us from helping. And really, what they're doing is they're destructive. They're harming people. They're hurting our society. They're breaking our economy. They're damaging an entire generation of children with their sort of elitist, from behind the laptop, epidemiology or virology or public health. These blue checks, and they're also so captured themselves in a lot of ways with the money and the funds and the PR and the Q value and the fame and all that. It is such an insidious mix where these people have they think that they have importance, and they've been breathing their own gases for a long time, and it's just really, really, really damaging.
So Kelly,
Let
me ask a question, then I'll follow up. Who presented this slide? Who presented this paper at the meeting? Because I didn't watch the meeting, either the FDA one or the
I didn't watch them either. Like I said, I didn't even know they were in that. Let me pull up, because I have three separate people had it in their presentations. So let's see here.
How did it, what was the, here's why I'm asking. The CDC has this data. I know people are calling this a study, and okay, it's a study, but really it's funny
it's
to
me.
CDC, it's a query. That's
right.
Exactly right. That's exactly right. There is some analysis, but not much. It's
a query within an essay.
That's exactly right. And so the CDC has this. So I don't understand why they need a preprint, or would even allow a preprint from a group of UK doctors. That what happened?
It said what they wanted to say. That's the bottom line, is whether it was intentionally fraudulent or whether it was just an ideological bias. They saw something that listed COVID as a top 5 death, and they went, well, that'll be perfect,
right,
for convincing people to approve this. And I don't even have
this. I'm not kidding. Like in an academic, I'm just speaking like in I'm thinking of a university community. Like these would be fireable offense. I'm not talking about the preprint authors. I'm talking about the allowing of and all of that.
Even if you think you're trying to help, this is a fireable offense.
If they didn't ask these super basic questions, and even just literally looking, I don't think I have it printed out, looking at the sources list at the end of the preprint is all you needed to look at to see that they weren't using underlying cause of death data, because they link, right to the NCHS data file that includes multiple causes. So you didn't even literally look at the source, and then you used cumulative when you knew it was being compared to a single year. So if they're not asking those basic questions on this preprint, what other basic questions are they not asking about the other data they presented? Like you would mention, Jessica, the hospitalization thing where they compared vaccinated and unvaccinated. Well, in one of those lines, the unvaccinated was before the vaccine was available. So of course the vaccinated people had no illness because there was no children vaccinated in that age group in that time. Right. But yeah, Catherine Fleming Dutra, who's here in Atlanta, she's a pediatric ER doctor who works for the CDC now. I don't know if she still has her ER role as well. So I actually emailed her and haven't heard back. So she cited it both with the ACIP and the FDA. It was also used by, Dr. Matthew Daly, who's with Kaiser Permanente and chairs the CDC's panel on COVID vaccine work group. And then Dr. Sarah Oliver, also a CDC official, used it multiple times the following day. And the panelists found it compelling data. Now, when people share it, obviously they're sharing it because they find it compelling data. But if I point out that it's wrong, they say, well, the ranking doesn't matter, is what a lot of people have disputed. I'm like, Well, then why is everyone sharing it?
And why are they leaving it up?
Not very relevant.
And why are they leaving it up after you've pointed out, and a lot of us have pointed out very, very clearly, and with factual data to back it up, very simple data.
Yeah.
Why are they leaving it up? And again, I think it goes back to what we were just discussing, which is they don't care. They think that it's close enough for government work, right? And it fits their narrative and it suits their goals.
It's compelling.
That's it. That's awful. That is absolutely awful.
Is the Twitter bio of the main CDC guy who says, I may point out factual errors in tweets or whatever. And I'm like, oh, look, I also point out factual errors in tweets, and you probably want to do something about that. And nothing. No response, no acknowledgement. Jerome Adams has shared it repeatedly.
Jerome Adams is an idiot.
He's not a smart man.
He's really not a smart guy, and it's appalling that he was even anywhere near the top levels of our public health and government.
So yeah, Julia Rafeman shared it, then deleted the tweet when she found out the preprint was being redone, but then retweeted somebody else who had tweeted it out the next day. And I mean, it's bizarre. And then the Caitlin Jetalina, the local epidemiologist, she didn't acknowledge any of the responses, but she did post a second thread that said, well, there's some nuance. You can either look at cumulative or annualized. And that's where
what about both at the same time?
Called her out and said, this isn't nuance. This is a lie. If you use 26 months of data and you compare it to a year of data, you are lying. And if anybody on the other side did it, you would be the first to call them out, but because it suits the message you want to get across, we're not calling it out.
And to your point about the CDC logo on this stuff, sort of the appealed authority of
the logo, but it definitely came from their slide deck, and it's identifiable once you see kind of the whole slide.
Well, but you know what I'm saying? Like the idea that this is coming from the CDC.
It's been blessed.
Right. And so most of the media, most of the normies involved, and even some of these, so-called, grifter doctors, Twitter experts, they appeal to authority. They say, well, if the CDC has endorsed it, then it's good enough for me. And who are you to question the CDC? But the irony is that if you really talk to them, and I've talked to a lot of people that I know who should be way smarter about this than they are being. They actually assume that the CDC is internally doing what we're doing right here. And they refuse to admit, acknowledge, investigate, look, see that the fact is they're not only not, they're sort of going out of their way to allow sloppiness. And it's really, really concerning.
I mean, this is the third thing I've corrected at the CDC
in
the last few months, just in the last few months. And that doesn't even include all the things that pointed out that were wrong that they didn't correct.
Right.
Well, actually, yeah. And then there's
the tracker. I know you keep track of the tracker more than I do, Kelly. Has the tracker adjusted? I mean,
they took a whole bunch out when they made the big adjustment back in March. Then they added a whole bunch in like a week or two later to kind of undo a lot of that fix. But it's gone up and down since. And some people freak out every time it loses some numbers. And I'm like, because these numbers aren't that great. But we corrected them when they had 5% of COVID deaths being in young kids or something. So we corrected that. They corrected the data tracker. They've corrected this. There was a preprint, well, not a preprint, an MMWR about COVID cases in a Georgia school district, a year or two ago? Now it's been a while that I corrected that they had all the wrong case rates for the county at the time. Then they said they were using one kind of testing and they were using another kind of there was multiple changes to that preprint that I pointed out. There was another one I pointed out and got a response, but they
never ending
to the rug.
What's funny? All those MMWRs, they have 1 million authors, 1 million. So it's all these people are willing to put their name on this, but it's do they all read it and analyze? It's a fascinating.
And there's no accountability.
It was about my county. So I was like, those were not our case rates. I just knew off the top of my head. I was like, that's not correct. And then when I went and looked at the actual footnotes and the details, I was like, oh, and you say you were including antigens, but you weren't, or vice versa. I forget. There were several issues. And I was like, all of these things are wrong. And And I said, and also you're using the reported by dates, but this was like months later. I was like, seems to me like you'd use, because we actually have the case onset dates for Georgia. I said, well, it seems like you would use those to get the actual sense of what the case rates really were, because the reported case rates are so delayed. So it made it look like this outbreak happened when the case rates were much lower than they actually were, because so much of the reporting was delayed. And they said, oh no, we use the reported by dates because something, like they had some bizarre explanation. And I was like, what? I think they tried to say they felt like it was more accurate. And I was like, well, it's clearly not more accurate. Like, it's based on when the lab submits the report to you. Like, that's not an accurate picture of when the infection happened. That's why we have that epi curve with the actual onset dates. Is like, we know that the actual infection occurred before the lab report gets submitted. And during a surge, lab reports are notoriously delayed to where they're way understated on the way up, and then way overstated on the way down.
Yep.
So I was like, I just was stunned. And they did make a bunch of corrections based on what I said. But there was still like, that issue was still just like, oh no, we wouldn't want to use those numbers. It's just sloppy work. And like in this, it's like they used someone else's sloppy work and then made it worse by their presentation of it, which was just, and
again,
I was like, I ran to my computer when I saw that, because I think I was on my phone, and I like ran. I was like, OMG. I was like, this was used in the ACT.
Yes.
I was just floored. I was like, this isn't just some shoddy slide with some sketchy numbers. Like, this was used
an important
in such a high profile way. And it was kind of my same reaction when I realized they were using the cumulative, because at first I was just like, of course, it's the multiple underlying. And then when I was like, and they're using I was like, and this. I was like, this, every time I look at it, this gets worse.
It reminded me of SCOTUS, when Sotomayor was talking about, the hundreds of thousands of kids in the ICUs,
yes,
on vents or whatever, and it was just like, that's why these things are so horrible, and they're so awful, and they're so insidious, because they come out, they get a stamp of approval, and it takes so long and so much effort to kill them with fire. And even then, you really don't ever kill them with fire. And the people know it, right? The Fausts of the world, like these idiots know it. They leave it up. They bake in it. And in the CDC, in the places where there should be accountability, there is none. There is none. The person or the people that did this will never, ever be called out. They will never, ever be disciplined, and they will never, ever be fired. And they should be. They should be called out, embarrassed, driven out, and never allowed to work in public health again. And it's not going to happen. And until that starts to happen,
to emails about it. I've
crazy.
emailed them. Journalists have emailed them, and we can't get a response.
But they don't have
why
to.
Did you use the wrong number?
Why would they have to?
There's no accountability.
There is zero. They don't have to do shit. Excuse my French. They don't have to do anything. They are completely protected. And I don't know whose job it is. I'm assuming it's Congress's job, but they ain't doing it, and they know it. Again, like, the only place to get called out is on Twitter by us. And, maybe if we're lucky, it burbles up to like, Fox News or something.
Yeah,
We
need some whistleblowers. I mean, I know you said earlier, like, internally at the CDC, is anybody doing what we're doing? I don't know. There's a part of me, and maybe it's the Hollywood side of my brain, but that says like that. There are employees that know for sure at NCHS, right?
Somebody could be a hero. Absolutely.
People who have been analyzing mortality data for decades, right? Like, there are real experts. And I have to believe that there's, people in like dark offices, on their coffee breaks.
Right.
And
who care, who are honest.
Right, who are honest and they know, and maybe it's only a matter of time. We'll see. So I remain hopeful that that the truth will come out, because we can see the truth with the publicly accessible data, but when you're in the midst, and I think we're toward the end of the mass delusion psychosis event we've been experiencing for the past
you think
years. I think so. I think we're toward the end, but as people kind of emerge, I think that the truth will trickle out, and we'll be here with receipts. That's the important thing, right? We knew. People be like, we didn't know. We did know. We knew.
And we said it too. Said
Right?
it consistently and loudly.
Yeah, yeah. So what's next, Kelly? I mean, you're watching this like a hawk, I know. Every day. What do you think? I mean, do you think when's the preprint going to be ready? I guess we could always speculate.
I mean, they said this week. I'm waiting. This will be interesting.
Yeah, it doesn't take long to fix this, especially with 11 authors.
I mean, it's a quick. They already sent me some data that I think is what they're going to end up using. So we'll see.
Yeah.
I mean, it was a cell phone screenshot. Like you can do this on your phone. This isn't a.
Right.
I mean,
It's a clown show.
like
Who are these people?
computer scientists on this study or whatever. You know,
These people are a joke. These people are a joke.
There's no computer science necessary for this. I mean, it's literally a search.
You know, if it's this easy to get a preprint, I mean, let's just write one. You know?
Well, that's what somebody's like. Until you write your own preprint, you don't get a say in this. And I was like, well, if I knew the standards were so low, like
put something together. I mean, how hard can this be, right? Like, not hard, apparently. So, right, we put some graphs and charts together, and yeah, put it out there. Like, you know, COVID is not dangerous for, you know, nearly every child. Like, we can't say this enough. Yeah, well, and now that the age 0-4, I mean, what do we think? A little bit of a transition here before we wrap up, but what do we think the uptake is going to be on the baby vax, as people are calling it? Like, what's your best?
Depends on how many mandates they put in place for it.
That's true. The poll numbers aren't good for them.
Own opinion, it's going to be less than if you start having to do it if you want your kid to be able to attend daycare or swim lessons or whatever else, which we know will happen in some of these.
The poll numbers aren't great for it, honestly. I tweeted about this the other day. I forgot exactly what they were, but it's only like 27%, I think, were like yes. And everybody else was like either
down.
Yes.
I think the uptake's going to be less than 20%. I mean, 1 dose, 2 dose, right? I don't know. I mean, that's anybody's guess, but I think I don't. What was the national uptake for 5 to 11 fully vaxxed? Was it 35%? I'm guessing there. I haven't tracked that. It was.
I'm not sure. And a lot of those are, again, because they had to for
right.
You know,
or
to
counties driving it in the state, right? Like, you know, my county was high for Illinois for the age 5 to 11, high-ish, maybe 50%, maybe a little more.
I mean, some of that is the ideology of the people in the area, but some of that is, you know, the restrictions placed on children if they don't have this.
Right. Or a family wants to travel, right? Or they wanted to go on a cruise, or they wanted to whatever. Right. So people made, I mean, and I really am an advocate for, like, you make the decision you want to make. Like, I'm not going to critique you. I'm not going to, right? I mean, for me, there has to be a direct medical benefit to something in order to even consider it. But, you know,
I didn't really have an issue with the idea that they wanted to authorize these to make them available, but I was super disappointed in the should recommendation, because that does set the way for all these mandates. It's not a may, it's not a, you know, for high risk kids, we recommend it. They have gone full force. They're all over the news. You know, this is something all kids need to keep them out of the hospital, to keep them from dying, to keep them from getting long COVID, even though we don't have data on any of that being actually effective in that age group.
Well, and an emergency use authorization for
that was what I was going to say.
But it can be limited. Do you know what I mean? An EUA does not have to be okay.
It should be.
This is for everyone. You can authorize something for a very limited group. Leave it to the discretion of doctors. Can't they already give it off label?
No.
Okay, no, they can't.
There's no off-label. The CDC has said you could be risking your license in this. So that has been one of the issues, I understand.
Okay, well, fair enough. But like to get an EUA, and I think Americans have kind of lost sight of, like, this is not like the full approval.
Yes, and that was going to be my point. Right, that's why I'm not okay with this, because this is still, you know, they're still claiming emergency, right? These are still under EUA, and I don't think that you can make that case. You know what I mean? The numbers just aren't there. It's not an emergency anymore. And to Jessica's point, you know, if we wanted to approve these things for EUA for anybody, like, it has to be a limited subset. It just has to. And this is literally like, you know, everybody, you know, have at it. You know, EUA doesn't mean anything anymore.
we also haven't worked out the compensation if there are any issues. Is still an open issue as well.
What do you mean?
For the people who do have it's still because of the emergency and stuff. It doesn't go under the normal vaccine court for compensation if you have any issues.
Unless it goes on a schedule.
I'm sorry, okay.
Yeah. Nothing's been paid out as far as I'm aware. By
of course, there's reasons why it's still
alternate,
EUA
or whatever.
Right?
Yeah, I don't know that it's specifically the EUA status that has an effect here, but the fact that it's still that we're still under this emergency and that this is still being all done under this cloak of,
right,
not the normal process or whatever.
Amazing, shameful, but
so
yeah.
We're going to have to do this again, unfortunately.
Yeah.
Well, we're going to have to, because something else is going to come up, or or
Exactly.
this new preprint is going to be revised preprint is going to be just as bad with different kinds of errors, but the same conclusions. So, well, Kelly, we can always rely on you to just be watching the pediatric numbers really closely. I know we're all going to be in touch, but we really appreciate your work on this. It is pro bono, right?
Yeah.
Everybody knows it's pro bono. It's just a passion of Kelly, and that's true for a lot of Team Reality people. Like we don't have an MO in all this, right? Like our dark money checks have not yet come in the mail. So
there's a lot of other things I wish I would have been doing this weekend and so far this week. Other things that were on my schedule besides dealing with some horrifically inflammatory and inaccurate data from the CDC, but that's what happens.
Anti-vax platform, Kelly. That's what your trolls say. So
I used to, when it was hard to find the vaccine, I was posting regularly with links of where you could find it in Georgia. I've helped people schedule vaccine appointments for people that are older and have trouble with the systems. But I think the calculus is different for kids. I think the whole concept of mandates and these strong should recommendations seem misguided.
Especially when they're based on bullshit.
Kids vaccinated. I mean, I'm no issue with that. I don't argue against it, but I do argue against using bad data. And I've pointed out bad data that goes the other direction. Like somebody was mad at me because there was an article that cases were going down in Georgia. And I was like, no, they aren't. They're going up. And they were like, shut up. And I was like, no, I mean, they are going up. Like people
gotta be consistent.
Like, I'll call it out if I see it. If somebody posts something that's just absurdly not factual, I'm going to tell you. Like, if it's data that I know in the back of my hand, like, which is so much of this stuff, these numbers, I see right away. And I'm like, that's wrong. Like, I don't go research every single thing that gets posted, but there's things that I just know off the top of my head are wrong. Yeah. And I don't let people get away with that.
No, that's good.
Well, thank you for that.
They just ignore me, apparently. In the case of Jerome Adams and others.
Whatever. Well, we tried, right? We've so many people have been gracious to him, and then no, thank you.
We try. We still try.
Exactly. Well, we appreciate your work, Kelly, and I'm sure we'll all be connecting again. But you guys have a great day. I hope it's beautiful and sunny where you are. It is
hot as heck here.
Always is. Atlanta? Come on.
100 degrees. No, it's way hotter than usual here. We're hitting records.
Some sweet tea, Kelly. Go get yourself some sweet tea. Lemon.
I am not a native Georgian. So.
All right.
So you're going to melt.
No, I grew up in Texas, so I'm used to this.
All right, guys. Take care. Thanks so much.
Bye-bye.
Bye, everybody.